are obviously relevant for free through recovery. So we have the care coordination plans, which is going to be kind of your go-to document as far as what are this person's goals, how am I helping them towards those goals, and what have we already accomplished, and then also what are we going to be working on accomplishing in the future. So that's kind of your home base as far as documentation. Case notes are really helpful in accenting, what it is that you're doing on a week-to-week or day-to-day basis that is kind of showing progress towards the goals that are on that plan. And then Mallory is going to talk a little bit about the things that we need as far as discharge requests, the types of information that we need to be able to make good decisions about whether, it does make sense to discharge someone from free through recovery, or if we should sort of continue to encourage their participation. I don't know that there's any others that are probably super frequent that wouldn't fall into one of these categories. Some things I can think of are releases of information. Other than that, yeah, that probably is kind of it. Okay, so moving on to slide 3, just some general things to kind of think about that are important with documentation. So timeliness is hugely important. As a clinical person who sees, sometimes like 8 clients a day or something like that, it's very easy to get behind on documentation, and then it's very difficult to get caught up. So for me, I just find that it's extremely important for me that I get a note done or get a piece of documentation done before I see that person again, because if multiple
Just a reminder to please mute your microphone. We hear a little dog barking in the background. For me, like I was saying, it's just important to get that note done before I see the person again. If multiple meetings start to pile up and I haven't documented them, that is when I start to feel really out of control, and it's hard to remember then, what exactly happened and what contribution did I make from meeting to meeting, and it can just become a landslide very quickly and get very out of control. And then it's extremely hard to get caught up. So we want to make sure that we're always documenting the purpose of the meeting. Why are we interacting with this individual, and what are we hoping to accomplish that day? We want to make sure generally that notes and documents have sort of a professional structure and tone to them. I've seen some pretty casual language in free through recovery notes, which is fine in most circumstances. I think just for the most part, we want to stick to the facts, and not add in different opinion kinds of things. One of the biggest issues that I've seen far and away in free through recovery documentation is unexplained gaps. So what I mean by that is, the last note that is entered for a person says, we will meet again next week. And then 5 weeks have gone by and there's not another note. So it's hard to know in those cases as an outside person looking in, did this meeting take place and it just wasn't documented, or did the meeting not take place? And if it didn't, what is going on with this person? Are they still going to be involved with the program? What do they need? There's just lots of questions that are unanswered when there's a gap in documentation like that. Or sometimes I've seen, that the care coordinator said that they would follow up with the person the following week, or that the person was going to call them the following week, and there's another note entered, again, 3 weeks later or 4 weeks later, and there's no attention paid to, like, what happened in between time. How come the person didn't follow up with you, or how come you didn't follow up with them? Like, what was that about? So there's nothing in the note that shows this is why we didn't get to follow up within 1 week. So just make sure that information is provided. Sometimes there's really good reasons why follow-up doesn't happen when we plan for it to. So it's just important to actually put that in the note. So for example, if you said you were going to see someone the following week, and then next week comes and they didn't call you, or you called them and they weren't available, just a really quick note in the file indicating, I called this person and they didn't answer the phone. I'm going to keep trying. Or
this person texted me and said that they couldn't call me because they were going on an unexpected vacation and they would get in touch with me when they got back, just whatever it might be. Just have the information in the note. And then again, kind of following up with that documentation of any missed appointments and why, to the extent that you're able to have that information. So you don't always have to meet with the person or talk to the person to do a note. You can document, this person didn't return my text message or didn't answer the phone when I called or didn't call me back or whatever. And then we definitely want to document if the person is going to be discharged from free through recovery or if they're going to transfer to another organization. So sometimes I would see, the last note said this person is going to, do whatever thing towards their goal, and then I'll follow up with them next week, and the person has been discharged from the program. So I'm sure there's information in the discharge request about why that happened, but it would be nice to have another case note just kind of wrapping things up. Right there in the chronos, in the case notes. So moving on to slide 4, this sort of already touches on what I just talked about, but I think it's just a good reminder to document anything that you do that relates to a particular client, not just those face-to-face meetings or phone calls. So if you make a phone call on the client's behalf, trying to set up services for them, if you review their records, if you have a conversation with a probation officer or somebody else on the client's team, staffing their case with that person. If you do have contact with family members, so if a family member calls you or if you have a release of information where you can be contacting that family member, we definitely want to have those contacts documented as well. So moving on to kind of the care coordination plan and the documentation review form. So those of you who got the email, the Free Through Recovery team put together a form that kind of works like a rubric. So it sort of tells you what to expect as far as times that the team would be going in and auditing documentation. So if you have that form in front of you, that's what we're going to be working off of. If you don't, we'll definitely make sure all of you get it, and that we follow up with your admin staff to make sure that they are, like your agency admin staff, to make sure that they're forwarding emails on to you or that we have your updated contact information. So there's a few different elements of things that we're going to be looking for on the care coordination plan. One is just very simple. Is there a care coordination plan that's created at all? The next thing is looking at whether the care coordination plan was created within that 10-day window of the person's referral, or if it wasn't, right, is there a valid reason? Did the person not ever follow up? Just kind of what's going on. And then we want to make sure the care coordination plan contains at least one goal that's active for that person. And then right on the documentation review form, we're going to be looking for evidence that the goal follows those SMART goal guidelines. So is it specific? Is it measurable? Is it attainable? And is it relevant? So when we look at whether it's relevant, we're going to be trying to figure out if it corresponds back to some sort of identified need that the person has, or corresponds to an outcome or something that's kind of linked back to the overall reason that they're in the program, some sort of behavioral health need, a housing need, a substance use recovery need, just whatever it might be, and kind of bumping back to that LSIR assessment and those big 3 risk domains there as well. The time-limited piece, we want to make sure that there's some sort of timeline expectation. When do we think it's realistic for the person to accomplish this goal? And then we want to make sure that each goal has at least one corresponding objective. So an objective should follow that SMART kind of set of guidelines too. We want to make them specific, measurable, attainable, relevant, and time limited. So the goal is kind of the overarching thing that the person wants to accomplish, and the objectives speak to what is the person actually going to do to get there. So for example, the goal might be to get housing, for the person to get their own apartment. So the objectives are going to be what are the steps that the person needs to take to get that goal. Maybe it's making a housing assistance application, or finding out 3 different places that have open rentals that are in budget. It's going to be those really action-oriented items, like I said. So that is mostly what we're looking for. And then we also want to make sure that the care coordination plan has a summary of what the client's current needs actually are, and then also a summary of the client's strengths. So we want to make sure that we always keep those strengths in our mind so that we can help the client leverage them to be successful and meet those goals. So that is basically the elements and the things that we're looking for that would make a really good care coordination plan. It's sort of difficult to take questions through this format, so we'll probably save questions till the end. So if you have something, just kind of make a note of it, and then I'll be happy to answer questions either on the phone or through the chat box at the end. In terms of case notes, so, here again, I kind of touch on timeliness. In DOCR for our clinical staff, the general expectation is that the note needs to be completed prior to the next meeting, like I said. So sometimes we have groups that are 5 days a week. So it's really important for that group leader to make sure that they do their notes every day before they leave. Otherwise, like I said, they're going to get behind really quickly, and it's hard to write a good note when you've lost sight of what happened in each different meeting. So we have that expectation mostly for staff's sake and to preserve the quality of our documentation and to help them manage their time and stop the process that happens when you get behind. But generally, the goal is to get most things in within 24 hours, and if we can't do that, then we definitely want the note to be done prior to the next meeting. So we just really encourage people to make a habit of completing that day's documentation and notes before you leave for the day. We set up our schedules, so usually from 3:30 to 4:30, our staff are still at work, but they don't have any client appointments because residents, that's a count time that we do in the prisons, and so residents aren't able to be out and about attending appointments and things like that. But what that does is help them set aside that hour at the end of the day where there's no meetings, there's no nothing, and they have that space free to finish up whatever documentation that they need to before they go home. So like I said, timeliness is really, really, really important. From an ethical perspective, a risk management perspective, and just a care planning perspective, right? You, as a care coordinator, want to be able to go back to your own notes, too, and get reoriented, especially if you have more people on your caseload, to be able to get reoriented to, okay, where are we at? What should we be thinking about during this meeting, and what is the progress that's been made? So with case notes, we want to be clear and concise, but we also want to provide enough information. So one of the other things that I've seen pretty consistently in free through recovery documentation is comments like, okay, this person's really struggling right now. That's good information to have, but we need more, right? That raises a lot of questions for me. What are they struggling with? Are they struggling with urges to use? Are they struggling with an increase in depressive symptoms? Are they, struggling financially? Like, what does that look like? And then the next piece, so I'm on slide 7 if you're following along. The next piece is focusing on documenting what you did to help. So a lot of the questions that I have when I look at notes and I see something like this person's really struggling right now is, okay, care coordinator, what was your response to that, right? What did you offer them? Was it a crisis line resource? Was it an offer to call you the next day or for you to call them and follow up on, how they're feeling the next day? Was it making an appointment to get in with their clinical provider? Is it, making a plan for them to go to an AA meeting or an NA meeting or something like that? It could be any number of things, but you really want to make sure you document what it is that you're contributing to that person and what you're doing to try to help them. If they don't choose to follow up on it or take that help, then we know that can happen, but we just want to make sure that the note says, like, what did you do with that information? And then we want to make sure that we're commenting a little bit. If there's anything you notice about the person that seems different or outside of their norm, are they displaying a concerning behavior? Did they say something that kind of was odd and struck you as either a change for them or something that would be troublesome? So for example, I have a client who is doing really, really well, but he got really mad about a particular situation, and he said, I just don't know why it's worth it for me anymore to try. That's not something that's typical for him. Usually he's very future focused and focused on his goals and what he wants to accomplish, and so a statement like that definitely told me that he was off of baseline and he was irritated and was maybe at risk to do something that he would regret later. And so if someone makes a statement like that, I mean, we want to take note of that. Or if they come in and they're, usually they're clean and dressed nice and everything, and then all of a sudden they start coming in and you can tell they're not keeping up with their hygiene. A lot of times those things indicate that the person is struggling with their mental health. So those are things that are going to cue you into, okay, what's going on? And then we want to document changes in motivation level. So that speaks to the example I just shared too. If the person usually comes in and they're really ready to identify their goals and work on things, and then one day they're coming and they're like, I'm not sure you can help me, or I don't think it's worth it really to try anymore. Or the flip side, right? If sometimes they come in and they don't seem like they're that motivated, don't have a lot of energy, and then one day they come in and they're like, I'm going to get 10 things done in the next hour. You want to make sure that you're just kind of paying attention to those things and putting them in the note when it makes sense to do that. We want to make sure we're documenting if the person did make progress toward a goal or if they didn't, and if they didn't, why not, and then documenting that plan for follow-up. I have seen a fair amount of notes, too, that just don't have any information in there about what the plan is. So the note might say, I met with this person today, and we talked about their job and how it's going really well, and they're living with their girlfriend, and they're kind of having some conflict, whatever, and it wraps up the note. And then it just doesn't say anything about when are you going to have contact with this person again? What does that look like? So we want to make sure that we know from the notes how often are you going to meet, when are you going to check in again, just sort of what's going on. And then with the case notes, so I'm on slide 8 now. If the case notes, we want to make that link back to the care coordination plan. So we want to make sure we can tell in the case note that you were working on something in that meeting that was relevant for that individual's goals. So anytime you can link back something that you talked about or something that you did in a meeting to something that's on the care coordination plan, that's going to be important and really nice to see for that continuity. And then I talked about this a little bit already, but I think it's worth emphasizing for sure. I like to say if you open a door in a note, you need to close it. So the example I used, Mr. Johnson is really struggling right now. Okay, that opens a huge can of worms in my mind, right? Is that person going to attempt suicide later today? Like we don't know. So we have to provide more information that would be able to kind of close that up and let us know how he's actually doing and what he needs. So another example, sometimes I'll see things mostly in clinical documentation. This person hasn't slept in 4 days. Okay, that's bad. That is not good. We need to know why. Is it because they're using? Is it because they're having anxiety and panic attacks? What is going on, and what are we going to do to help that individual deal with that issue? And then another example would be, Mr. Smith stated he doesn't currently have access to transportation. Okay, that's going to be a huge barrier too. That to me is an open door, right? And something we have to solve now and at least try to address. So what are we going to do to try and fix that or try and address it? I just read a note from a counselor in the prison that said, basically, she went to see the individual and it said, yep, he's in a psychotic episode right now. He's having hallucinations and delusions. And that was it. And I was like, that's not okay, right? Okay, it's good that we know what the problem is. However, our role is to really help that person get the resources they need. So we can't just leave it at that. We have to show what we did to follow up and help that person make sure they have the care that's relevant for them. I think we mainly talked about this slide already on slide 9. The only other thing I would maybe add is that you can set up like a general framework for your sessions as far as a schedule for the session or like an agenda for the session, and then you can reflect that in your notes. So you're going to want to start with, why am I meeting with this person today? I'm their free recovery care coordinator, and we're having our weekly meeting. Comment on anything that you've observed that might be different for that person, those behavioral observations. You're going to want to talk to them about whether or not they followed up on any prior goals, kind of making that bridge back to the last time you talked or the last time you met. and then look at if they didn't accomplish what they said they were going to accomplish, what were the barriers, how are we going to problem solve around those, and are there additional resources that you need? And then once that bridge from the previous meeting is kind of wrapped up, move into, okay, what are some new goals? Are we going to continue to work on the past goal, or are we ready to set another one and make a plan to try and accomplish something new? And then the last piece is going to be talking with the client and documenting what is the plan for follow-up. When do you want to see me again? When do you think you need to meet with me again? So you can really reflect that flow of the meeting and agenda for the meeting in your note. And I think it's helpful to have a guideline or like a template set up like that when you go to do your documentation, because it makes it a lot easier to actually sit down and do it when you have like a general sense of the different areas that you need to comment on versus just starting with a blank box and trying to think about, okay, what do I need to write here? Some other points generally just to kind of keep in mind, we want to use person-first language as much as possible. Different clients have different preferences about this. You know, some people I've worked with have definitely identified themselves by their disorder to me. They've said, you know, I'm a borderline or I'm a bipolar or whatever. That's not how I identify them, and it's definitely not how I identify them in my documentation. So we want to refer to a person diagnosed with schizophrenia or a person who has schizophrenia instead of a schizophrenic in most situations, you know, or a person that is dealing with substance use issues instead of an addict. And again, people's personal preference is different, and some people prefer to be referred to by those terms, and we can respect that. I don't generally put terms like that in my documentation, though, unless I'm going to say, you know, this person is insistent that I refer to them in this particular way, and so that's why I'm doing it. We want to avoid use of pejorative terms like inmate or subject or offender. In my mind, client is better, but I try to just use the person's name as much as possible. John or, you know, Darren or whatever, Mr. So-and-so, whatever level I'm on with that individual. And then you always want to stick to the facts. So by facts, I mean, what did you actually observe for yourself, or what did the client tell you? And so anytime the information is something that you didn't observe for yourself, you need to indicate where you got that information. So the Mr. So-and-so reported that this happened, or, you know, the PO told me that this was going on, or I read in a chrono or something like that, or in a piece of collateral information that this person had this issue in the past. You just want to cite back to the source of where you got it, unless, like I said, it's something that you actually observed. And, of course, we don't want to use any belittling language or unfair judgments. I saw, this was quite a few years ago, but I saw a clinical note one time that said that the client was being gamey. And I just thought it was really unfair, right, because there was no, it was a judgmental opinion type of term. There was no evidence, at least not documented, that would have supported something like that. And even if the person was, you know, a lot of times in the prison we'll have people who will, like, say that they're self-harmful because they want to go into observation and get away from, like, their roommate or something that's stressful for them in the general population. So if that's happening, we can't just call that gamey and write it off. We need to share what is actually happening so we can address it. So that's a really specific prison example, but, you know, I would just, like I said, stay away from generalized statements that don't have facts to back them up or are judgmental or belittling, for sure. In terms of the discharge request, Mallory was going to walk through some of the pieces of information that are helpful for her to have on that document.
Yeah, so I think just in generally speaking, since DocStars was up and running, we've gotten a lot of more discharges. I think just because it's easier to walk through a discharge process rather than, you know, in DocStars rather than emailing myself and the officer and all that. So I just kind of wanted to go through some of the things that I've noticed and some of the things we're going to be looking for when regional admins will be doing, coming out and kind of looking at, you know, your case notes and care plans and all that. So we do ask when someone, and you guys may or may not know all this already, depending. I know we have a couple of brand new care coordinators on the phone. I know we have also the majority of you have been doing this for a year now. So
So in the discharge request, we ask for the final outcome measures. So just what you guys do every month for your participants, we ask for that. We ask for the information on the peer support. So really we just ask if they are connected to a peer support specialist. I think it's just a yes or no question. And then we go into asking about formal treatment or counseling, and if this item is answered and if comments are provided. I don't know that you have to answer or follow up each yes or no question with a comment, but the comments really are helpful. And when I can see a discharge request that has everything answered, including comments, it's really helpful for me to be able to make a decision right there instead of having to go back and forth between the officer and then you and all that. So keep that in mind. And then just a quick reminder, if we could mute our phones, there's a lot of background noise catching. I'm hearing a lot. Support. So we talk about if there's anything in the community that we don't ask about, like besides formal treatment or counseling. I know one way that care coordinators answer this question, and something that I appreciate, is if they have family members or friends, or if they have like a support group, things like that we look for in that question. And then if the recovery item is answered and comments are provided. So this will vary depending on who you're discharging. So we look towards how this question is answered is if someone was referred and the officer entered information that they have major depressive disorder. You'll see in that, sorry, there's just a lot of background noise catching, so if we could just mute our phones, that'd be helpful. So if the person is diagnosed with major depressive disorder and at the discharge question, we'll ask a question if they've made any progress towards recovery in regards to their major depressive disorder. So it's helpful. Sometimes I know a lot of the folks who we work with have multiple diagnoses. So we don't expect, really insane details, I guess, as it relates to that. But the more detailed you can be, the better. And then finally, there's a chrono section. So the chrono is pretty important, and it's like a time, I feel like, where it's a good time just to like sum up why you're requesting discharge and where things are at right now. In that chrono, if you could mention whether or not the officer is aware of the discharge, that's helpful for me, because I do tend to make sure the officer is aware that that the person has been discharged. And 9 times out of 10, whenever I reach out to the officer, if I don't see in the documentation that they're aware, they'll say, yeah, I'm aware and I'm fine with it. So there has been a handful of times where officers weren't aware, and I just learned the hard way by not checking with them, assuming that they knew. So if you could add documentation in that last chrono as to whether or not everyone's on board with the discharge, that's helpful as well. And then a couple other just last minute comments on the discharge. So timeliness is really important. I know oftentimes when I go through a discharge, I'll see that the last chrono for an individual in the program is from like 2 months ago. So let's say if I get a discharge request in March here, sometimes I'll look and the last chrono entered by the care coordinator is in January. So just make sure if you are in fact going to request discharge, make sure you do that soon after that decision has been made, just because it kind of creates, a couple months where that individual, even though you may not be working with them anymore, they're kind of taking up space on your caseload, or how that looks in DocStars is officers still won't, make referrals if it looks like all of your spots are full, but really you could probably take another individual. And then lastly, the categories. So those are pretty important as well. Usually, there's really no issues with the discharge categories that people select. If someone has been kind of MIA for 6 to 8 weeks straight, obviously that would be like no contacted or absconded. If someone flat out declines free through recovery and everyone's on board with that, then then you would just put declined or stopped participating. So usually everyone gets those categories correct. There might be some times where something changed and I asked you to maybe go back and recategorize the discharge. I know there's been times where someone was incarcerated and the care coordinator didn't know, so they put that as absconded, but really we wanted to change that to reincarceration. So you might see some emails from me just kind of trying to tie up loose ends like that, but for the most part, discharges, when they're completed well, and if I have follow-up questions or need more information, I'll just reach out and ask.
Okay, and then, all right, so that was kind of all we prepared as far as the training. It's hard to have discussion, like we said, in this format, although we will try to do a question and answer. So I'm on slide 12, but I think it's important to think about what are some barriers for you to completing that good quality documentation in a timely manner, and how do we problem solve around those barriers. So for me, I know that it's way better, like I said, if I can stay on top of it from day to day versus trying to set aside a whole huge chunk of time to do a bunch of documentation that I'm behind on. That doesn't work for me. And if I overschedule my day, then that's not going to happen, and I'm going to be in a bad place. So one of the things I mentioned, like I said, is setting aside time each day that's reserved for documentation and treating it like you would a meeting, right? So you wouldn't skip out on a meeting with another person, so don't skip out on yourself, right, and your time that you have set aside to do your work and what you need to do. So now if there's any questions, we're definitely happy to answer those. Probably the easiest thing to do if you're at a computer is to type your question into the chat box. If you're not at a computer, though, you can let us know, and you can definitely ask it over the phone.
All right.
Okay. Well, like we said, we will make sure all these documents are available to you, especially the documentation review kind of audit form, because that will tell you exactly what the team is looking for when we pop in and look at some of the care coordination plans and case notes. Did you have anything else?
No. Thanks everyone for joining. I know we're gonna for those folks who couldn't be on this call or join via Skype, we did record it, so we'll be sending out that recording here hopefully before the end of the week.